Thanks for the invite. Thanks for the invite, sir. It was a mesmerizing group discussion, a panel discussion, and I would hate to put an end to it. So then we'll have a brief discussion on EGFR mutated
You can
advanced lung
mesmerize us
cancer.
further for the next 10 minutes, Akash.
Sure, and we'll try to shorten the discussion so that others do not suffer. So CA lung, we know, is one of the important malignancies that we are faced. CA lung per se accounts for a large number of cancers and a significantly larger number of deaths. As we had discussed in the panel discussion before, that a large number of these patients are detected in advanced stages, and hence their outcomes are compromised and their mortalities are higher. In our practice, most of the patients that we see are either stage 3, stage 4 lung cancer. And with the advent of the EGFR, with the advent of molecular testing and targeted therapy, the outcome of a lot of these diseases have changed. So we'll briefly discuss the first line options for EGFR mutated CA lung, which are locally advanced. So we broadly have three options: the first generation, the second generation, and the third generation TKI, with the other options being the combination with BEV and a combination with one of these, with the first generation TKI with chemotherapy. So the slides are restricted to these three options. The third generation TKI or osimertinib as first line is discussed first because it is something that has the best data. So in a patient who has sensitizing mutation for EGFR, and if it is detected prior to initiation of systemic therapy, to give one of the EGFR targeted TKI is the standard of care, and osimertinib is the preferred agent, of course, because of the overall survival data from the FLORA. If we have started on systemic therapy, we either continue with the same therapy or stop and shift to one of the TKIs. Most of us do the latter or add it to the ongoing chemotherapy, which we can discuss. The prime benefit that osimertinib has is that it is an irreversible binder to the EGFR ATP binding site of the EGFR, and it does two things. The wild type EGFR is not very strongly affected, so the toxicity of the second generation TKI is not seen. And second, that it crosses the blood-brain barrier, and hence much of the survival or the data or the benefit that we are seeing is driven by this fact. So we know that osimertinib has three primary things that we need to know about. One is that it inhibits, of course, the sensitive mutations. It inhibits the T790M mutation, so has a broader coverage. It crosses the blood-brain barrier and has lower activity against the wild type EGFR, and hence has lesser toxicity as compared to the second generation TKIs that we'd see as we go ahead in the presentation. So FLORA trial was a landmark trial in the treatment of EGFR mutated advanced lung cancers, in which the sensitive mutations were either randomized to osimertinib versus the first generation TKI. The primary endpoint was PFS, but the data that most of us were interested was that of overall survival. So PFS, when the data first came, we thought that osimertinib would actually bulldoze everything out, because the hazards ratio was around 0.46 with a PFS, median PFS of 18.9 months versus 10.2 months. And all subgroups, irrespective of their gender, the smoking history, CNS metastasis, what mutation that they have, each of these subtype benefited with osimertinib rather than the first generation TKI. When we see the overall survival data, though it was positive, of course not as emphatic as the PFS data was, the overall survival, the hazards ratio was 0.79. So there was a 21% reduction in the risk of mortality or death, because of for any cause mortality. We also see that at 3 years duration, around 28% of these patients were alive and still taking therapy, which I think clinically is a very a relevant point. Even if though the survival also improves, but that we are able to continue the patients on same drug for a long period of time is in real world very important, because we know that a lot of patients, once they progress on the first line, there may be one of the following factors that he or she may not be able to take therapy. One of those factors could also be relatives and friends who may offer them alternative medicine. So in that case, probably in the real world scenario, that PFS also comes out to be very important, unlike in treatment of such metastatic diseases. Time to subsequent treatment was prolonged with osimertinib as compared to the first generation TKI, and the hazards was around 0.47. When we do a sin of comparing trials and doing a cross-trial comparison, we see that the PFS with osimertinib was around 18.9 months versus 14.7 months in decotinib, and subsequently the other drugs, the PFSs were small. And this PFS and OS benefit, as we had discussed, was seen across the group, except for say L858R, where though it was a subgroup analysis and we may not draw many conclusions out of it, but it crossed unity there. So all other groups actually benefited, and probably the Asians in the subgroup analysis. So when we see the first generation TKI, the point to be noted is that the PFS still remains around 8 to 10 months in the approval trials also, and in the data that we have from the country also. So a shorter PFS. Second generation TKI, so we have two, decotinib and afatinib. Decotinib was, when it was studied, there were two major issues that we had. One was that the study excluded patients with brain metastasis, which forms an important group of patients with EGFR mutated lung cancers. They may have it initially, or they may progress with a brain metastasis. So that was one factor. And the second issue with the drug was, of course, the toxicity. And the third issue that we see in the Kaplan-Meier curve was that when we look at the PFS, the separation of the graphs start far earlier with osimertinib as compared to decomitinib. So though the OS data numerically looks very impressive with decomitinib with 34.1 month, there were two things, of course, with the trial design. It could not be proven statistically significant. And the other issue was that we are excluding a large chunk of patients with brain metastasis, so that also helps the drug. Here, osimertinib we know has a statistically significant difference. So we come to the second generation drug, that is afatinib. We know that it could not show an overall survival benefit. But there are two important things about the drug. One, that it is cheaper than the others, but of course it has higher toxicity and hence falls out of favor. The other issue is that of brain metastasis. So when we look at patients with EGFR mutated lung cancer who have brain metastasis, osimertinib seems as the ideal treatment. The reason is that the drug crosses the blood-brain barrier, and this is a unique characteristic that I think is probably the major characteristic that separates it from the masses. And this was proven both in the preclinical trial, in the clinical trial data that we have and we'll discuss, and in the clinical practice that we see. So in FLORA trial, both systemic and intracranial efficacy of the drug was analyzed. And when it was compared to gefitinib, we see that the benefit was startlingly better. So the hazards ratio in terms of PFS, both in patients who had brain metastasis and who did not have brain metastasis, the hazards ratio was around 0.47, which is significant and eye-catching. So when we see in the period of time, patients were known or treated CNS metastasis, around 43% of these patients had progression over the course of the trial in Flora, as compared to 19% in osimertinib. This difference was 3 versus 7, pointing out the same thought that osimertinib crosses the blood-brain barrier and gives a better CNS control. So in brain metastasis, the approved therapies are the IOs in EGFR mutated tumor osimertinib, in ALK mutated tumor alectinib and ceritinib, brigatinib, etc. Now the third important point. So I said one was the longer PFS and the OS. The second we thought was the penetration, the CNS penetration, and the third and most important, one of the important things was the toxicity of the drug. So osimertinib, we see is a drug that is better tolerated, and predominantly for the reason that it does not significantly inhibit the wild type EGFR, and hence it leads to a lower drug discontinuation rate as well as a lower rate of dose toxicity. So when we compare this in Lux 7, afatinib, almost 41% of these patients required a dose reduction. In dacomitinib, this number was for 66% versus around 4% in Flora. So this gives us a visual impression of the safety of the drug. So similar things are represented in the next few slides, and in the with paucity of time, we'll move on. Now, the fourth important thing that we see is that should we sequence them? So a second generation or first generation TKI followed by osimertinib versus osimertinib at first line. We all in our practice are constrained by the cost and the logistics. Putting that one factor aside, which is probably the most significant factor for a lot of us, we see that when we give osimertinib as first line, we give the longest control. When we give another standard of care EGFR TKI, we get a PFS. And of course, in patients whom we are able to detect a T790 mutation, we may offer them the drug again and get a longish survival. But a large proportion of these patients would either not be a fit for second line therapy, or in a lot of our practice would probably default and start taking some alternative medicine. And a chunk of these patients will not be T790 mutation, or will not be able to do a biopsy. And hence, like in a street fight, it is always better to give the best punch first. So the other issue that was, so it is a visual representation of the same thought, that a lot of patients die after the first line therapy and they receive PAL care only. Some of these patients are not eligible for T790M mutation, so they cannot be tested, and hence we could not give them drug. And who are tested, a small chunk of them come out to be positive. So at the end, we are only able to treat a 1/3 of the patient. Another argument of this often quoted is the GeoTag study, and we'll very briefly discuss it. GeoTag basically was a retrospective study in which patients who had received afatinib first and had then progressed and were tested and were T790 mutation were given osimertinib. There were certain fallacies in this trial which we always call out, was that this selected out the best patients. Patients who were given afatinib had a longish control, but who progressed, but we were able to biopsy them, or we were able to do a liquid biopsy, prove that it is T790 mutation, and then give drug. And because this ideal scenario does not play out in our practice routinely, hence, whenever given the opportunity, we must land our best punch first. So, summarizing, osimertinib demonstrated a clinical and statistically significant improvement in overall survival. The median OS is greater at 3-year time than benchmark. It is the first time that a TKI, EGFR TKI, has translated its PFS benefit into OS. Almost 30% of the patients would receive on this drug for a long period of time, and thus this drug is safe. With this thought, I'll just take a minute of the session and we'll time to on how we practice is that though we offer osimertinib to all patients, but in patients who are not able to take the drug, we give them either the first generation TKI with chemotherapy. In patients who are able to take the drug, we offer them osimertinib. Thank you.
Thank you, Akash, and thank you for that lovely talk on how do we need to treat our metastatic EGFR positive non-small cell lung cancers. And all of us do agree now that for the right patient who has the right pocket, osimertinib is a good choice and probably the best choice available at this point of time. And the best drug should be going up front. Should be going up first, and that's with that thought, and that's how all of us have changed our practice. We now come to